So when we talk about malingering evaluations, we really use the term symptom validity testing. But in my poll of colleagues, when I talked about symptom validity testing, I got these blank stares. So when I said malingering evaluation, they're like, aha, I know what you're talking about. That's why when I was developing this, I said, just go ahead and bill it as malingering evaluations, and that way I'll maybe get some more people interested. And look, here you are. So malingering is really based on secondary gain. And another term for malingering might be dissimulation. You might have heard that. Someone actually said in one of my courses, don't you use the term dissimulation, because in the CDCR, the party line is you're not allowed to diagnose malingering. And the reason why is because when Coleman came in, and Coleman is, there was some lawsuits, I'm not going to get into it, but Coleman is the monitoring agency that comes in and makes sure that CDCR is compliant and is treating all of the inmates with their psychological needs and medical needs and doing the things that we should be doing. So what Coleman did was they came in a number of years ago and they looked at all of the not all of, they looked at a sampling of records, and they found that people were being diagnosed with malingering and not necessarily then receiving the services that they needed. Or they were diagnosed with malingering and then taken out of the program and then decompensating or whatnot. And one of the things that we know is one of the #1 groups of people who malinger are people with real mental health problems. Why? Because they know how. In fact, there's a lot of studies that are out there that say that the #1 group of people who malinger on the street usually live in the East Coast or northern states, and usually malinger more often during cold months. They go into the hospital and they've decompensated. Does that mean that people with psychosis decompensate more during cold months? No, it means that the hospital is warm and dry and offers 3 hots and a cot. So that's where some of the research has come from. So no, I don't use the term dissimulation, which is a general term to describe someone who just deliberately distorts or misrepresents psychological symptoms. It's not necessarily that they are malingering so much as they might be defensive, right? So I don't use that term. Also, coming back to not using terms that people might not know or jargon, when I first heard the term dissimulation, I had to go look it up. If I have to go look it up, and I consider myself a little good with, playing words with friends, anyone know? All right. If you want to play words with friends, I totally play with you. But the fact is that if it's a $5 word, I'm probably not going to use it too often. So, words that I often use are things like feigning, so things that we need to pay attention to when we are doing any type of malingering evaluation are our own personal bias and deception. So oftentimes you won't necessarily be called in to do a malingering evaluation. You might. It's possible. I actually love those. More often than not, you're going to be adding some of these instruments into an evaluation that you're currently doing. Anytime you're doing a forensic evaluation, the standard is to add a symptom validity test. Anytime you're doing a neuropsych evaluation, the standard is to use some sort of symptom validity test, usually a test of effort. And we're going to get into what all of that means right now. So this is the definition of malingering per the DSM-IV-TR. And he has a disposition that malingers on. Malingering has been known since the dawn of time, in essence. Nietzsche writes about it as there is only one world, and that world is false. The father of forensic medicine says there is no disease more easily feigned and difficult to detect. And of course, the Bible has David, fearful of a king's wrath, feigning himself mad. So there's references that go on and on talking about how people have feigned mental illness for secondary gain. There are many different areas that you can have malingering. Legal context of evaluations is one of the biggest. Personal injury. People want some money. That's what it comes down to. Lack of cooperation during an evaluation and treatment is something that we need to pay attention to. Antisocial personality disorder, someone's already been diagnosed with that. Keep in mind that they might have a higher chance of malingering. But above all, in your evaluations, look for inconsistencies. You're looking for inconsistencies between what the person tells you. You're looking for inconsistencies between records and what the person tells you. And you're looking inconsistencies across. Why? Secondary gain can include a number of different things. Avoidance of criminal responsibility, trial or punishment. Avoidance of military service. Financial gain. Avoidance of work. Social responsibility. How many of us were sick in high school when we really weren't sick? Yeah, only 2 of us, all right. And then the rest of you are dissimulators. So. All right, what about facilitation of transfer for, okay, well then, I'm sorry. How many of you are sick at work when you're not really sick and you just have to stay home and you call that number and you're like, I'm sorry. It must have been something I ate. But then the next day you're miraculously better. All right, facilitation of transfer from prison to hospital, admission to a hospital, and drug-seeking behavior. So there are a number of different reasons why people secondary gain in institutional settings it's rampant, and that's why I've done so many malingering evaluations. And I think of myself kind of as a malingering expert, although I run across inmates every day where I have to learn something new, so hey. They're trying to find medication, maybe for sedation or intoxication effects. Maybe they want a housing cell because single cell seems a lot better than living in a dorm with like 500 other inmates. Maybe they're trying to get SSI when they get out of there because they want a paycheck. Maybe they want special yard or privileges. Maybe they just want more time out of their cell because being locked up for 24 hours a day is not conducive for good mental health. Maybe they want to go to mental health groups. Why? Because apparently mental health groups are really good for trading drugs. Yes, an inmate told me that once. Maybe they're trying to get appeals. So if they pretend like they're mentally ill and they get in the mental health system, it will help them on appeals. Yes, an inmate has told me that as well. And maybe they're just trying to delay the court process in the incompetent to stand trial piece. That's right. If you're developmentally disabled, you can't be executed. So maybe they're trying to avoid punishment in that way. But remember, just because he's malingering doesn't mean there are no deficits. Some of the best malingerers are individuals with thought disorders, and we already answered the question as to why. So some common disorders that are associated with deception include substance abuse. Why would that be associated with deception? That's right, to get more substances. Sometimes if you have an alcoholic in the family who's a working alcoholic, he goes to work every day, comes home every day, and then he drinks, and his old lady's getting tired of him drinking, so instead of coming home and drinking, he drinks on the way home so that he can still get his drink on. He gets really good at deceiving. No, honey, I haven't had anything to drink. Personality disorders are often common with deception. Can we name a couple? Can we mouth a couple? Antisocial personality disorder, probably number 1. But what other personality disorders are really good at deception? Borderline. Yeah. Those are the number 1 and number 2. There are a few others. We won't get into it. But what about eating disorders? Research shows that eating disorders are also really common to deception. How come? Because you have to hide that you have an eating disorder. All right, it's getting late. It was too early before, now it's getting late. So these are some of the differential diagnoses that Rogers outlines. Conversion disorder. I have a really great story about conversion disorder. How many of you have met someone with conversion disorder? One. What was yours?
Paralyzed arm.
You had the part. Oh, that was kind of cool. I had hysterical blindness. This guy comes in for an SSI evaluation, and he was being referred because he was going blind, and he could no longer work. And when, okay, I talked to him. He tells me just straight up that, yeah, it's just in the last couple of years I've started losing my sight. Doctors don't know what's wrong with me. I'm like, well, how's it affecting you? Well, I can't see. I'm now staying with my friend. I lost the house. I can't work. I like to work. I'm a woodcutter. He's a carpenter. Loves working. Kind of upset that he can't work, but not depressed. Not really flat affect, but totally not really interested in the fact that he can't work. Not really upset about it. Not really upset about losing his house. Not really upset about losing his eyesight. And I'm going through the clinical interview, and at one point I'm like, so what big thing happened to you 2 years ago? No, nothing much. And I kind of go through the timelines of all the stuff, and I'm like, you know, you said you broke up with your wife. You know, you separated from your wife 2 years ago. What happened? Well, I walked in on her and my best friend, and they were in the middle of sex, and I just walked out of the room, and it was one of the most kind of profound moments, because I'm like, conversion disorder. You know, it was like one of those moments that you learn about something in school, you never expect to see it, and there it was, right in front of me. Someone who had no interest in helping himself, but totally just thought it was him going blind after seeing his wife having sex with his best friend. I recommended SSI, but I also recommended a lot of therapy. In any case, conversion disorder is something to rule out because it's unconscious gain, i.e. not having to see the world around him or any other horrible thing, and non-intentional symptoms. It's not something that he wanted. It's certainly not something he was just making up. He couldn't see anymore. Factitious disorder is another thing to rule out, which has unconscious gain and intentional symptoms. So tell me about factitious disorder. Has anyone seen this? What's the #1 known factitious disorder? Yeah. Have you seen it? Munchausen. Which is what?
Well, Munchausen or Munchausen by proxy?
Either.
Well, for Munchausen by proxy, it's when parents actually make their children ill so that they can be portrayed or perceived as a good caretaker
right.
or parent.
But as you can see, something to rule out because it's an unconscious gain, wanting to be thought of as the great parent or you poor dear, you're sick, but intentional infliction of something. It's intentional, the symptom is intentional, like you're purposely making yourself sick so that you can go into the hospital and be taken care of, or you're intentionally making your child sick so that you can be seen as the great parent. If you ask this person, you know, why do you do this? They won't say, so I can be a great parent. They'll probably say, I don't know. So the unconscious gain, the gain is unconscious, but the symptoms are intentionally made. Whereas malingering is both. Conscious, because you know you're going to get that medication, single cell status, big paycheck at the end of the lawsuit, and intentional. So when you're doing a malingering evaluation, these are some things. How many of you have heard of Ganser syndrome? So Ganser syndrome is a rare dissociative disorder that was previously classified as factitious disorder. It's characterized by nonsensical and wrong answers to questions and doing things incorrectly. It's often found in correctional settings. So it's where someone will give you approximate answers. You'll say, what's 2 + 2? And they'll say 5. And you're like, That's interesting. Most people know what 2 + 2 is. And then when you go through all of the different testing, you'll have very inconsistent tests and scales, and you'll be like, what's going on with this? So what to rule out? Always rule out real illnesses, factitious disorder, somatoform disorder, and then Gardner syndrome. Malingering in the criminal justice system. Base rates of malingering are estimated to be between 8 and 17.4%. Competency stand trial assessments, about 60,000 referrals in the U.S., and you see the malingering a lot there. And then surveys of psychiatrists and psychologists working in forensic setting say that malingering actually occurs between 16 and 18% in the forensic setting specifically. And there are different models for So the criminal logic model is another one. It's where people who have antisocial personality disorder tend to malinger, and they are seen as bad. The reason this person with antisocial personality disorder malingers is because they're bad. The person is seen as chronically conning people. Why? For secondary gain. But it's just part of their nature. The problem with this model is possible denial of problems or organic problems that might be leading to feigning. Not everyone who malingers is bad. It might be some other reason. So the adaptational model is the one that most people use. The reason why people malinger is because they're faced with adverse consequences, circumstances, and they have a cost-benefit analysis, so that's why they tend to feign whatever they're feigning.